Bonjour tout le monde.
Hello, everyone,
Bienvenue à
and
notre
welcome
série
to our
Summer
Summer
Symposium
Symposium series,
série sur le
a
bien-être
series on the
des vétérans
well-being
et de
of
leurs familles.
veterans and their
Je
families.
suis le docteur
I am Dr. Remay
chef de la
Zacharias,
direction et directeur
President,
médical
CEO,
du Centre
and Medical
d'Excellence
Director
sur la
of
douleur
the
chronique.
Chronic Pain Center
I
of
would like to
Excellence.
take this opportunity to thank our presenters today, Dr. Jason Bussa, who is the Director of Research at the CPCOE. This will be followed by Josie Pierre, who is the Manager of the Pain and PTSD Clinic at St. Anne Hospital in Montreal. Merci à tous.
À Montréal. Thank you to everyone for joining us today. I would now like to give the floor to our moderator, General Michel Maisonneuve.
Merci, Dr. Zacharias, et bonjour, chers amis. I welcome you to this latest in our series of webinars on veteran and family well-being. As mentioned, my name is Michel Maisonneuve, and I am a veteran of the Canadian Army. Once again today, there are two streams to choose from, a French language stream and an English language stream. We're doing simultaneous translation to serve both streams. The presentations and slides are best seen in full screen mode. The first presentation today will be in English with simultaneous translation on the French language stream, and the second one will be in French with simultaneous translation on the English stream. I've been working with the Center of Excellence on Chronic Pain since its founding, and it gives me a chance to give back after my 35 years in uniform. Chronic pain is often a constant in the lives of our sailors, soldiers, and airmen and women while serving. Unfortunately, this pain usually follows them into their retirement. The mission of the CPCOE is to contribute to finding ways to treat this pain through research and developing a network of pain clinics across Canada. Now let's get on with our seminar. Today we will have two presentations and we'll take questions after each. I'd like now to introduce our first presenter. Dr. Jason Busse is the Director of Research for the Center of Excellence. As such, Dr. Busse leads the research efforts of the center, including, for example, the use of cannabis to treat chronic pain. He's an associate professor at McMaster University in the Department of Anesthesia and the Department of Health Evidence and Impact. He's director of the National Pain Center, associate director for the Center for Medicinal Cannabis Research, and pain lead for the Division of Perioperative Care at McMaster. He was the principal investigator for the 2017 Canadian Guidelines for Opioids and Chronic Non-Cancer Pain, and he's published more than 250 peer-reviewed studies with a focus on the management and prevention of chronic pain. Dr. Busse will provide an overview of the veteran population who are suffering with chronic pain. He'll explain who has pain among the veteran population, how pain levels are categorized, the impact this pain has on their activities, and explain how pain sometimes is accompanied by other issues. Dr. Busse, over to you.
Good afternoon. I'm here today to speak about a research project that we have recently completed, looking at identification of care need clusters in Canadian veterans living with chronic pain. I have no disclosures to make. This was an unfunded project. Now, why did we undertake this study? Well, it's important to understand the prevalence of chronic pain amongst veterans, but there's also reason to believe that the presentation, the experience of living with chronic pain is quite diverse. There's a lot of heterogeneity. Some veterans are likely to be severely impacted by their chronic pain, and others may be less impacted. And that's going to have implications for the kind of healthcare services that are going to be most helpful to each of those examples. So chronic pain is common amongst Canadian veterans. We do know that, but we need to make policy and pursue research and provide healthcare resources that are accountable to that group and to the composition of that group. Now, our hypothesis going into this study is that we anticipated that the majority of veterans living with chronic pain might have less severe needs They might do reasonably well with, let's say, sort of limited intervention and access to services. There would be a smaller group that would have more intensive needs, and a smaller group still that might have very intensive needs and a lot of associated comorbidities. But we didn't know if this was going to bear out. So we began by using data from the Life After Service study, which was last acquired in 2016. And we identified all veterans who endorsed that they were living with chronic pain. And this was 41%. So not quite half, but a substantial number of veterans. And to give this some context, that's about double the prevalence that the typical Canadian population would endorse. So it's quite high. Now, what distinguished veterans that live with chronic pain versus those that did not endorse living with chronic pain? Well, they were more likely to be female veterans. They were more likely to report lower household incomes. And they were more likely to be dissatisfied with their finances. They were less likely to be working, and they were more likely to be receiving disability benefits. They were more likely to be senior non-commissioned rank members and to have put in more years of service with the military. They were more likely to have reported physical and mental health problems, extreme life stress, suicidal ideation, and difficult adjustment to civilian life. And unsurprisingly, they were much more likely to be a client of Veterans Affairs Canada than those veterans not living with chronic pain. Now, because this is a cross-sectional study, we don't know the direction of these associations. So, for example, it could be because someone is living with chronic pain that they are experiencing life stress, or it could be that experiencing life stress is more likely to result in the experience of chronic pain. We don't know because all of the data was collected at the same point in time. Now, we used 5 features which seem to be helpful in terms of separating veterans that live with chronic pain into 3 clusters. And these were the intensity of pain that they reported, the degree of psychological stress that they reported, the number of symptoms of post-traumatic stress disorder they endorsed, limitations that they experienced in their activities of daily life, and activities that they reported were prohibited by their chronic pain. And by using these 5 features, we had some separation of this group of veterans living with chronic pain into 3 clusters. The largest of which was cluster 1, that was almost half at 47%. And cluster 2 and cluster 3 were fairly similar in terms of their representation at 26 and 27%, respectively. So what did we see when we looked within these clusters? Well, first looking at limitations that they reported experiencing with their activities of daily life. In cluster 1, there were no individuals that reported they actually required assistance to complete their activities of daily living. There were about 15% that reported no limitations, and 85% reported they had some limitations. But again, 0 required assistance. This changed quite a bit when you go into cluster 2 and then cluster 3, where you have a majority of the individuals indicating they required assistance to complete at least some of their activities of daily life. So again, cluster 1, some limitations, none severe. Cluster 2 and cluster 3, both reporting a fair bit of limitations with their activities of daily life. In terms of post-traumatic stress disorder symptoms, you can see that the majority of those veterans in cluster 1 reported no PTSD symptoms. And this was similarly the case for cluster 2. A very different picture emerged for cluster 3, where the majority of those individuals did endorse quite a few symptoms of post-traumatic stress disorder. In terms of psychological distress, both cluster 1 and cluster 2 reported, by and large, very low levels of psychological distress in comparison to cluster 3, where the majority reported experiencing significant psychological distress. In terms of looking at the number of activities that were prevented by their chronic pain, you see a pattern whereby all groups do have some limitations, but they are predominantly clustered in cluster 2 and cluster 3. And in terms of the intensity of pain, you have about a third of individuals in cluster 1 that reported their pain as mild in severity, and the remaining reported it as moderate, really with only 2% reporting their pain was severe. And again, you see a much different picture emerging for cluster 2 and cluster 3, where it's only a minority that are experiencing mild pain, and most are experiencing either moderate or severe pain as part of their chronic pain experience. Now, if you see different levels of intensity of complaints, different levels of intensity of limitations, you would imagine that that might be reflected in the intensity of care utilization. And this next slide gives us some indication of the care-seeking patterns of veterans within these 3 clusters. So in terms of family doctor visits, again, all groups are seeing their family doctor at least once per year, but you do see the trend there where you get about 23% of cluster 1 are attending for 10 or more visits per year. That goes that's about the same in cluster 2, but cluster 3 is up to 34%. So some increased care utilization as you go across the clusters. In terms of talking to a mental health professional, a very sort of small proportion of those in cluster 1, only 17%, goes up to 35% in cluster 2, but in cluster 3, that went up to 77%. So certainly the cluster with the greatest endorsement of PTSD symptoms, of psychological complaints, are also accessing healthcare professionals in the greatest proportion. In terms of those individuals within each cluster that had been overnight in a hospital for healthcare reasons in the past 12 months, only 6% of those in cluster 1, that doubled in cluster 2, but it went up to 20% in cluster 3. So again, we see this increasing needs of healthcare system as we go across the clusters. And in terms of being a client of Veterans Affairs Canada at the time at which this data was extracted in 2016, the majority of veterans in all 3 clusters were clients, but it goes up considerably across the clusters from a low of 62% in the first cluster to a high of 95% in the third cluster. When we look at the distribution of rank by cluster, senior non-commissioned officers are really fairly stable across all the clusters. But where we see some variability is in the officer and in the junior non-commissioned military rank positions. So we have a decreasing proportion of officers as we go from cluster 1 up to cluster 3, but we see an increasing proportion of junior non-commissioned military personnel going from 28% of cluster 1 up to 41% in cluster 3. What about physical well-being? Well, we did have information from this survey about overall physical health. This was captured by a well-validated instrument called the short form 12. And what you can see on this graph is in cluster 1, there was some reduced physical well-being compared to population average, which is represented by that red arrow that says mean, but it's not substantially less than population averages. You get a different scenario for both cluster 2 and cluster 3, both of which fall significantly below population averages for physical well-being. When we look at mental well-being, we see a different picture emerging, but consistent with some of the other information that we found. So again, here we find that both cluster 1 and cluster 2 endorse overall mental health that is similar to population averages, whereas cluster 3, which, as you will recall, had the greatest proportion of PTSD symptoms, was seeking mental health care at the greatest proportion, and endorsed the highest levels of psychological distress, they again are coming quite a bit below population averages in terms of overall mental well-being. What about comorbidities? Well, almost everybody, or the vast majority of individuals in all clusters, reported living with chronic musculoskeletal complaints. And that's the very first comorbidity at the bottom of this graph. And you can see that that's 80% or higher in all of the groups. And this is to be expected. Military service often involves a great deal of physical training, a great deal of fairly aggressive activity that we know is associated with musculoskeletal problems after release from service. But the real differentiator here, once again, is as we look at mental health comorbidities, post-traumatic stress disorder, anxiety, or depression, this is where we see cluster 3 really predominating again. So the cluster 3 is the red bars, and you can see that they are far and above beyond what the other 2 clusters report in terms of these mental health comorbidities. So again, these 3 clusters are not entirely unique. You obviously do see some presence of mental health comorbidities in the first 2 clusters, but not to any degree to which they are present in that 3rd cluster. So in conclusion, in our study of veterans released from service between 1998 to 2015, they reported chronic pain at a prevalence of twice the general Canadian population. We identified 3 clusters within these individuals reporting chronic pain, and they were not entirely distinct. There was some overlap between them. However, in general, what we found was the majority of veterans fit into cluster 1, which did report limited physical impairment and minimal psychological distress. Cluster 2, which was 27%, reported more severe pain and quite a lot of physical limitations and impairments. And cluster 3, which was 26% of that population, reported not only more severe pain and physical impairment, but significant representation of psychological distress and mental health problems. And these findings have implications for both policy and research. What this tells us is chronic pain is not the same experience for everyone. And it's going to be important to ensure that healthcare resources are tailored to fit the needs of the individual. Not everyone is going to require the same services, but there certainly is a very high needs cohort that is going to require more intensive services in order to see the benefits of care. And I'm happy to take any questions. And if you have any interest in seeing the full paper that has been recently published in the Canadian Journal of Pain, and it can be accessed through here, through the internet. It's there's no paywall. It's open access. Thank you very much.
Thank you very much, Dr. Busset, for this very interesting presentation, and especially the impact that this will have on research and treatment of pain in the future. So we've had you, the audience, submit some questions in advance. So I'm going to ask Dr. Busset now to respond to these. First, can you briefly explain what both a cross-sectional study and a cluster analysis are?
Yeah, absolutely. Point in time. So we put out the questions and people provide us with information, but we don't have the benefit of following people forward to sort of understand, if, for example, psychological complaints might be associated with chronic pain, or if chronic pain leads to psychological complaints. So it's a type of study where we get information at a single point in time. In terms of a cluster analysis, what we do is we look for characteristics that show variability amongst respondents. And if there's variability, so some respondents report many symptoms of PTSD, some report moderate, some report few, then that gives us an opportunity to try to use those features to define clusters of patients within the overall sample. So we found 5 baseline features that appeared to be quite variable amongst our participants. And we use that in order to try to develop meaningful clusters to help us understand amongst those individuals that report living with chronic pain, can we determine different groupings so that we can understand implications for both research and healthcare needs?
Now, the hypothesis at the beginning of your presentation linked levels of chronic pain to different possible levels of medical intervention. Did you find that the three cluster groups could also be linked to those same levels of medical intervention?
Yeah, we see some association there. So again, we do see a baseline level of care seeking that is consistent. Everybody is seeing a family physician at least once per year, but we do see greater needs, greater visits as we move from cluster 1 to cluster 2 and then to cluster 3. And where that was particularly pronounced was with the access to mental health care providers, psychologists, and psychiatrists, where we saw very little of that in cluster 1 and 2, and a large proportion in cluster 3. And of course, that linked up entirely with the self-report of greater psychological distress, greater mental health comorbidities such as anxiety, and greater number of PTSD symptoms. So we saw care seeking across all three clusters, but we did see higher levels of care seeking as we move from cluster 1 to 3, and much higher levels of care seeking for mental health complaints within that cluster 3.
So one of the key findings of the study seems to be that junior non-commissioned members are more likely to be found in cluster 3, obviously those with the greater intensity of pain. Did the data provide any information to suggest why that might be?
No, unfortunately it did not, but what do we know about junior non-commissioned members? So that would be individuals that have rank below sergeant in the military. We know they're more likely to probably be the heavy lift. Be able to extract themselves from some of those more physically demanding pursuits they have to undertake. So they might be more vulnerable in that sense to acquiring injuries, for example, that might then lead to a greater burden of chronic pain after release. We do have evidence from other studies that suggest junior non-commissioned officers might have important differences in terms of training, education, socioeconomic status. They might be living under more sort of financial challenges than more senior members of the military. So I think it's complex. I think that the rank that they have is a surrogate for a number of other factors that we have to learn about to sort of disentangle the actual reasons for why most of those members are ending up in the third cluster that we found.
Yes, because, and kind of a follow-up to that is what's interesting is usually those will be the younger veterans as well. So, interesting how it doesn't really correlate from that point of view. Younger person you would think would be able to withstand pain better and be able to recover better. Have you looked at those?
Well, I do think that's true, but again, we are only looking at these individuals after they've been released from service. So we have to look to see, how long were they in service? We certainly found people that spent more time in service were also more likely to end up with chronic pain than those that spent less time and would have been released when they were younger.
Good. And how does this study tie into the future Center of Excellence research projects to further examine this issue and other issues?
Yeah, it's a great question. So, as we're sort of trying to determine what kind of treatments work for which individuals, it's going to be really important so that we only offer types of treatment to an individual that has those needs. So, for example, we could say there is a reasonable prevalence of post-traumatic stress disorder amongst veterans living with chronic pain. But if we were to provide treatment for PTSD to every veteran living with chronic pain, we probably wouldn't see an effect because the majority that we found living with chronic pain do not have a lot of symptoms of PTSD. So if we're going to design studies to look at interventions, we have to make sure that they're targeted to individuals that are likely to benefit from those types of care. Same with the sort of severity of pain. If we were to do studies with a lot of individuals from cluster 1, we might not see dramatic effects. They're not reporting high intensities of pain or large limitations in their function. So even an effective intervention might not see a big difference there. So it's going to be very important to use these results to ensure that we develop, therapies and treatments and trials needs and most likely to see a benefit.
That's great. Perhaps just to finish up then as a last question, while we're on the subject of research, could you give us an idea of the different research projects that are now on the way at the Center of Excellence?
Yeah, we have a lot of things underway, a lot of things wrapping up. We're quite interested in trying to understand the role of medical cannabis in the management of chronic pain, whether use of medical cannabis can help military veterans to substitute opioids. We have a couple of studies coming out where we've spoken with and surveyed veterans living with chronic pain to understand what their research priorities are. We're very much trying to align the actions of the center to be accountable to the primary stakeholders, which are, as you might imagine, veterans living with chronic pain. We don't want to conduct research studies that they do not see value in the question. We're looking at management of chronic jaw pain, which we now understand from speaking to Veterans Affairs Canada is the second most common chronic pain complaint that they receive requests for treatment for. We're beginning to look a little bit at the role of interventional pain therapies for chronic low back pain. We're trying to understand the differences in terms of gender and sex, in terms of responsiveness to care and the experience of chronic pain. So a lot of interesting things that are happening. We have a Veterans Advisory Council that provides us with essential input on what directions we follow. And every study that we complete helps us understand better the next studies that we should undertake to sort of continue our journey in trying to optimize recovery and prevention from chronic pain amongst veterans.
Well, thank you very much, Jason, for this very interesting information. And it's obvious that before you do research and before you carry on with trying to find solutions for those with chronic pain, you have to get a sense of where the pain is, who is suffering from pain, and what that population is. So thank you very much for that.
Thank you so much.
Merci à vous. Merci
J'aimerais
à vous.
maintenant vous présenter
I would
notre
like now to
deuxième équipe de
introduce our
conférenciers.
second team of speakers.
Madame Josie Pierre est une
Ms. Josie
gestionnaire
Pierre
depuis
has
plus de
been
10 ans.
manager
Elle
for
est la
over
chef
10
de
years.
service
She
de
is
la
the head
clinique de blessures
of the
de stress
Department of
opérationnel
Operational
et
Stress
du
Injury
service de
Clinic,
gestion de la
as well
douleur
as
de
the
l'hôpital
Department of
Sainte-Anne à
Pain Management
Montréal
at the
et à
Hospital
Longueuil
Sainte-Anne in
depuis
Montréal
2016.
and in Longueuil
Cette
since
clinique novatrice
2016.
fournit des
This
soins pour
innovative
les
clinic
blessures de stress
provides
opérationnel,
care for operational
mais
stress
aussi pour la
injuries,
gestion de
but
la
also
douleur
for the
chronique des
management of
vétérans
chronic
affligés
pain
par
of
ces
veterans
difficultés.
afflicted by these
Madame Pierre
difficulties.
détient un baccalauréat en
Ms.
sciences
Pierre has
infirmières
a BA in
et une
nursing
maîtrise
sciences
en
and a
gestion.
master in
Ses domaines
management.
d'intérêt sont la gestion,
Their
la
areas
communication
of interest are
et les
management,
relations humaines,
communication,
et
and
de
human
cette façon,
relations,
elle
and
peut
in this way,
contribuer à
helping
améliorer
to
l'offre de
improve the service
services
offered
pour les
for
vétérans.
veterans.
Elle sera accompagnée par la
She will
docteure
be
Isabelle
accompanied by
Cornell
Dr.
et le
Isabelle
docteur
Cornell
Michel
and
Gilles.
Dr. Michel
La
Gilles.
docteure Cornell est
Dr.
psychologue au
Cornell has been a
au service de
psychologist in
gestion
the
de la
pain
douleur
management
depuis
department
2006.
since
Elle occupe également les
2016.
fonctions de
She has also held the
coordinatrice
duties of
clinique
clinical
pour les services
coordinator
externes
for
BSO
external
et
OBS
de
and
gestion de
pain
douleur
management
depuis
for
3 ans.
3 years.
Le docteur Michel
Dr.
Gilles
Michel
travaille
Gilles
comme psychiatre à la clinique BSO de
has
l'hôpital Sainte-Anne à
worked as a
Montréal
psychiatrist at
depuis
the BSO clinic
2016.
of the
Il
Hospital
joue
Sainte-Anne
aussi
in
le rôle
Montreal
de
since
chef de site
2016.
pour les
Since
psychiatres de l'hôpital Sainte-Anne
2016.
depuis 1 an.
He has also played the
Ses
role of
domaines
site manager
d'intérêt
for
sont une
psychiatrist at the
spécialisation
Hospital
en
Sainte-Anne for a year. His areas of
psychotraumatologie
interest are
et en psychiatrie
psychotraumatology and
occupationnelle.
occupational
Leur
psychiatry.
présentation
Their
suivra dans les
presentation
traces de
will
celle du
follow in
docteur
the
Busset,
footsteps of
qui
Dr. Busset
examinera les
and
instances de douleur
will
chronique
examine the
qui sont
instances of
souvent
chronic
associées
pain
aux
that are
blessures de
often
stress
associated
opérationnel.
with operational stress
L'avantage d'une
injuries.
clinique comme celle
The
de
advantage of a
Sainte-Anne
clinic like
est
the one in
l'habilité
Sainte-Anne
de donner des
is the
soins
ability to provide
interdisciplinaires à nos
interdisciplinary
vétérans.
care to our veterans.
Mesdames, Messieurs,
Ladies,
à vous.
sir, over to you. Hello, I am Josie Pierre. I am the head of the Operational Stress Injuries and Pain Management Clinics at the Sainte-Anne Hospital. We also have a service point in Longueuil. Today, I am presenting the first part of the presentation, so the services, and there will be Dr. Isabelle Corneille and Dr. Michel Gilles, who will focus more on clinical aspects in the second half of the presentation. We don't have any conflict of interest with regards to this presentation. So, as I mentioned earlier, the objectives of the presentations are, first of all, to present the services as such, and secondly, to understand the state of the situation of veterans when they are when they have comorbidity of chronic pain and mental health issues. So the profile of our clients on March 31st, 2021. What are the categories of clients that we serve? We mainly serve veterans, and we also have members of the RCMP, active military members, and family members, and that they represent about 10% of our clients. So who refers the clients to us? It's mainly from Veteran Affairs, Department of Defense, and from the RCMP. So the profile of clients, we have a total of 1,082 clients for both services, and some of those clients receive services in Longueuil. Others receive services with the pain management section, and a large majority of them are also receiving mental health care at the DSO clinic, that is Operational Stress Injury Clinic. So it's a total of 30% of clients that receive services for pain management and mental health issues. In terms of counseling for pain management, we have some clients that receive pain management services. You can see the percentage, it's about 64%. So what are the types of services that we offer? In all three services, whether it be at OSIC or PMC, and also at the Longueuil service point, there are always interdisciplinary assessments that are conducted, whether it be with regards to nursing care, individual, group, couple, and family psychotherapy. And there's also medical and psychiatric consultations. And for pain management, we have rehab services in physiotherapy, occupational therapy, psychology, and there are other services also offered. There are also educational capsules. So as you see, the most important for nous are our clients. They're at the heart of everything that we do. You can see here the veterans, active military personnel, and the RCMP. They're at the center of everything we do. We start with assessments, and then we have draft response plans, and then we can choose what treatment will be offered to these clients, whether they be physical, psychological, medical, or collateral treatments, as we mentioned earlier. So once we finish, we make referrals towards external treatment. If the clients need to be seen again at the center, once they have been referred, we can reopen their file. You see that we have an interdisciplinary approach, and our teams are composed of professionals from all different categories. You can see that there are occupational therapists, clinical nurses, general practitioners, psychiatrists, psychotherapists, psychologists, social workers, and also the administrative support personnel, administrative officers, planning, programming, and research officers, managers, and such. I'd like to give the floor to Dr. Cornell now. Thank you, Josie. We're going to now talk about the clinical aspects, and we're going to talk about the different problems that veterans deal with on a daily basis. So in terms of chronic pain, it's been shown in the conferences that you've already heard that chronic pain is truly a frequent problem for veterans, Canadian veterans. For instance, for Canadian veterans that receive treatment, 80% of them say that they live with constant pain, 77.3% have recurring pain, and 71.6% say that the pain interferes with their daily activities. The data is quite similar for the U.S. So for clients that receive services from Veteran Affairs in the U.S., 50% of them say that chronic pain is prevalent. That's an important number. 63% of active military personnel and 43% of U.S. veterans are diagnosed with a pain-causing condition each year. And musculoskeletal pain-related issues are the #1 reason for medical releases in the U.S. 59% of 1,800 military personnel who served in Iraq and Afghanistan reported significant pain that exceeded the clinical threshold of 4 on a scale of 0 to 10. Very important data. There's another issue that the veterans have to deal with on a daily basis. It's the issue of mental health. There are a lot of issues with regards to mental health. In a recent national survey of Canadian veterans, it was seen that 23% reported being diagnosed with one or more mental health disorders. 5.8% reported also having suicidal ideation, and 1.1% reported an attempted suicide in the previous year. From 2002 to 2018, 45% of female veterans and 33% of their male counterparts reported symptoms consistent with a major depressive disorder. So very, very high numbers. The research shows also that 10 to 17% of returning military personnel are affected by PTSD. And another important bit of information is that almost all Canadian veterans diagnosed with PTSD also suffer from other mental health disorders. So added to PSD, there are often other disorders such as depression, generalized anxiety disorder, panic disorder. And we can also see that veterans with PTSD have poorer physical health than veterans without PTSD. For instance, people who have people who have PTSD have more gastrointestinal disorders and chronic pain than other veterans who don't have PTSD. So we've talked about mental health, we've talked about chronic pain. So what happens when we talk about both at the same time? What happens when veterans have chronic pain and mental health issues? Well, 50% of veterans report at least one chronic physical condition and one chronic mental health condition. There is a strong correlation between chronic pain and mental health disorders, the most prevalent being major depression and anxiety disorders, such as PTSD, generalized anxiety disorder, and panic disorder. Depression is the most common psychiatric diagnosis for people with chronic pain. And PTSD is very prevalent among people experiencing chronic pain, particularly veterans. So, a few statistics. 49% of patients treated in U.S. Veterans Affairs medical clinics report suffering from both pain and PTSD. 21.7% of Homeland 81.5% of U.S. military personnel deployed in Iraq and Afghanistan reported chronic pain, and 68.2% of them also reported PTSD. So these numbers are quite high in terms of comorbidity. And patients with musculoskeletal pain are 4 times more likely to develop PTSD than those who do not experience physical pain. So I think it's important to talk about comorbidity with the veteran population, because as we've mentioned it, many of them have both chronic pain and mental health conditions. So when the veterans try to explain to us what they are experiencing, I found a few drawings that clients have given me that really represent it well. Clients often explain that they feel completely overwhelmed. They don't know where to start to get better. They don't know what treatment team to go see. They feel overwhelmed by all the difficulties that they're dealing with, and they don't see the light at the end of the tunnel, the day that it's going to get better. And we know that patients that have comorbidity, for instance, PTSD and chronic pain, often are much more complex cases and difficult to treat. So it's recognized that patients with a mental health disorder and comorbid pain experience will have more severe pain and also greater emotional distress. They'll also feel a greater inconvenience or interference in their daily lives, a greater perception of disability, as well as higher levels of depression and anger than someone who only has chronic pain or only has a mental health condition. And what's important to understand is the complex relationship in this comorbidity. There is no manualized treatment of 12 sessions to say, okay, this is what we're going to do, you're going to recover quickly. That's not at all the case. And we also need to know that with comorbidity, there are many other associated problems. We talk a lot about anger. With this veteran population, there's also issues of addiction when there's no other solution at hand, relationship problems with the family, and other difficulties, which makes the situation even more complex. So, given all this information, I will now give the floor to Dr. Gilles, who will talk about challenges with regards to the treatments. Hello, I'm Dr. Michel Gilles. I am a psychiatrist. I'm here with my colleagues. And the patients who deal with comorbid pain and mental health conditions, they are often the same patients because they often have physical injuries associated with mental injuries and have had to deal with different traumas in their military service, which has led to comorbid pain and mental health issues, especially depression. We know that there's only one brain, there's not a brain for psychiatrists and a brain for others. So the association, chronic pain and mental health issues have comorbidity and can have an effect one on the other. So patients might often be shuffled back and forth between mental health and pain management clinics on the grounds that the other problem should be treated first. But the current practices suggest, rather, that it is best to treat both conditions in an integrated manner, so provide care for both issues at the same time. And in St. Anne, we are very lucky to have both services together, and physical proximity is very important for these two services for chronic pain and mental health conditions. It allows the teams to be more connected. It has been well established that most of the issues, mental health issues and comorbid pain, will be looked at as chronic illnesses. There are certain protocols established for chronic illnesses, and it's important to really use as much information as possible. So psychoeducation. The patient needs to know as much as possible about the conditions that they're afflicted with. If you have PTSD and you don't know what's happening, that increases the anxiety load. And we have to also provide emulation regulation techniques. And this is often associated with anxiety, hypervigilance. The lack of regulation techniques is associated with these. We also have to provide help for cognitive restructuring. Often there's a cognitive restructuring when you suffer from chronic pain and mental health conditions. And finally, there's also techniques for desensitizing faced with physical and psychological pain. Often people want to not expose themselves, but that can sometimes make it more difficult for the patients to recover. So we need to provide them with behavioral strategies. So the objectives of the care, integrated care provided for comorbid pain and mental health issues, and the same patients are affected by these, is to help clients to fully understand and integrate what they are facing, to know their conditions, psychological and physical, to really understand this and give them back a sense of control by providing tools that the veteran can manage him or herself. And so give them the feeling that they are controlling their minds and their bodies and allowing them to increase their ability to function in everyday life and also increase their quality of life. Unfortunately, these conditions are chronic. Some of these traumas go back 10, 20, 30 years. Now we don't have the technology right now that allows us to really target healing. Rather, what we are aiming for is a diminishing of the symptoms and improving the capacity of the veteran to understand and to self-manage his or her condition. This is a process that is difficult and often produces anxiety for the patient. The patient requires support and requires coherent messages between the disciplines. It takes time and certain modalities of collaboration and proximity for the services. So, of course, the challenges are considerable because in order to address complex problems, we can't offer simple solutions. We'd like it to be the case, but it isn't. However, it is clearly established that a better understanding of the condition and the determinants of the symptoms evolution will improve the quality of life and daily ability to function of veterans. So we have to encourage, support, and develop the interdisciplinary work within the teams, whether it be in mental health or pain management. And many patients have both problems. We have to make sure that these specialized clinics have a good deal of interaction. That means that there has to be a greater capacity to address these challenges. For instance, what is the place of the use of cannabinoids in physical versus mental health care? There's little scientific evidence that it should be used in mental health, but it can be used in physical health. So this will allow us to looking at this will allow us to make reasonable choices and realistic choices with regards to treatment for our patients. We are also lucky to have discussions about cases with both teams to look at use of opioids. Perhaps opioids are playing too great a role. To look at, and they also have psychological effects, and that can lead to a vicious circle. And this allows us to consider, for instance, using cannabinoids without necessarily leading to effects on the psychological condition, but they can be used to address physical symptoms. Medication is useful, sometimes very useful, but is never sufficient to heal these traumas. So the collaboration, the daily exchanges, or as frequently as possible between the two disciplines, allows us to avoid some of the traps, to find medical solutions and to avoid the ones that don't work and avoid the use of medications that are associated with secondary side effects. A large challenge that clinics like ours experience is to determine the role to play for cannabis as medicine, as a supervised medication, and cannabis that would be used in a non-supervised way, not monitored, and that could lead to a certain trivialization of the discussion on cannabis and the use of medical cannabis. So here again, the best interest of the patient is to try to find the best balance between the advantages, inconvenience, the risks in making therapy decisions. Thank you.
Merci beaucoup, Madame Pierre et
Thank
Dr. Cornell et Gilles. Comme on le voit, un vétéran blessé peut recevoir des soins interdisciplinaires à l'hôpital Sainte-Anne. Vous aurez noté dans la présentation que la première étape est l'évaluation du vétéran et que la deuxième étape, celle de la planification du traitement, se fait aussi avec l'apport du vétéran lui-même ou elle-même. Cette discussion et consultation avec le ou la vétéran sont essentielles au succès du traitement. Nous passons maintenant à vos questions.
We'll now go to your question. The first question is for Dr. Cornell. 50% of veterans report suffering from both chronic pain and mental health issues. Is this number the same for men and women? And have you seen an overall average increase or decrease over time?
Votre question est intéressante.
En fait, question. Thank you. Three things. Yes, 50% overall. Yes. Here at the pain management service, this goes up to 87%. 35% of clients come directly from the OSIC clinic, but we also have clients elsewhere in Quebec. So they come from Chicoutimi and other clients in the province that are also come from the mental health community, whether it be psychology or other. They also have a lot of comorbid conditions. In terms of the gender, our clientele is 78% male, 22% of women. That represents a little bit what happens in terms of the armed forces. But if you look at the clinical level, comorbidity, whether it be for women or men, is similar. So you see the same rates of comorbidity and the same sort of levels in terms of depression and anxiety. So in terms of gender, it's fairly similar. And are comorbid conditions more present or less present today? This question is a bit the question is a bit different, in fact. Things have changed. When we opened the clinic in 2006, we had the impression of having less people, but in fact, I think that wasn't the case. It just wasn't discussed as much. People didn't openly talk about mental health issues. They might have talked about chronic pain, but not mental health, and especially not about comorbidity. And with the years going by, people have been more vocal, have addressed these problems. There have been more services provided, and veterans talked among themselves. And today, I think we have a better view, a better idea of the situation and the comorbidity between chronic pain and mental health. And I encourage veterans to continue to talk amongst themselves and also to look for services, to request services, because comorbidity is a heavier burden to bear, and help is there. Please continue to avail yourself of it. Thank you, Dr. Gilles. When veterans arrive at the St. Anne Clinic and start receiving care for chronic pain and mental health issues, what is the biggest challenge they face before starting their their treatment plan? Thank you for this question. Yes, I think there's more than one challenge. Finding the courage to be able to expose yourself to a healthcare system that is often complex, confusing, and difficult to navigate. Being able to open yourself up and talk about your traumas and your injuries, something that you've tried to avoid talking about. That's a big step. The second step, and it's essential for me for all chronic conditions, is to try to get as much knowledge and understanding. The patient must seek to understand their condition. It's not easy because there are multiple symptoms, and you can't draw a line between physical and non-physical symptoms because it has been well established that mental health conditions lead to physical symptoms, a panic attack or pain. So where does one blur into the other? Where does do psychological problems meld into physical problems? It's very difficult to establish, and these two problems are linked and can also increase the severity one of the other, and that has been observed as we saw with Dr. Busset's presentation. So reassuring patients, welcoming them, and recognizing their courage in opening up is important. It's not enough also to hear things, you have to integrate them too. It's the same in a conference. You listen, but you want to also remember some of what you've heard. And when you're a patient, you're often stressed. So what is being discussed isn't always integrated and always absorbed. And that's important, that work of absorbing the message so that the patient can make the best decisions possible and also collaborate with treatment plans that are meaningful for them, whether it be tolerating side effects of certain medications. If you have fear, then you'll have side effects. If you feel more reassured, and if you can sort of control your life to a certain extent, whether this be physical or psychological, then it will diminish the level of anxiety because the anxiety is already there from the initial condition. If the person feels that, oh, they're not able to make decisions, they don't have any control, their body doesn't respond to them anymore, then that's more difficult. And I think it's important for the veteran to understand from where his or her pain is from and how they can manage their pain. So a question for Ms. Pierre. Is there a standard length, program length for veterans who attend the St. Anne Clinic? A good question. Yes, there is a program length, but first we have to distinguish between internal services and external services. We have an external clinic as well. Our program, our standard program, usually lasts about 2 years from the referral that we get to the assessment, going through the groups and the assessments and the treatments. All that takes about 2 years, and it corresponds also to the guidelines of Health Canada. But any intervention, whether it be chronic pain or mental illness, we won't simply say it's going to take 2 years and then it'll be over. No, but that's about the average. Great, thank you. Unfortunately, that's all the time we have. Perhaps for the other clinics that are listening in, the St. Anne Hospital can use its knowledge and the lessons learned for integrated treatment offered to people. So if the other clinics have questions, questions, I hope that they can contact you. Thank you very much to Dr. Busset, Ms. Pierre, and Drs. Cornell and Gilles for your presentations and your answers to the questions. As we have seen, the Centre of Excellence on Chronic Pain for Canadian Veterans, located at McMaster University in Hamilton, is working hard to contribute to the health of our veterans. The research sponsored by the Centre and the National Pain Clinics Network, which is being developed as we speak, are two aspects of the Centre's mission and have a direct impact on pain management care available to Canadian veterans. The Centre wants to ensure that veterans understand that there's hope and that their pain can be managed properly and that their quality of life will be improved. I remind you that today's session and all previous sessions are or will be available on our website. This webinar is the last of our series this summer, and we plan to hold more sessions this fall. Meanwhile, from the Centre of Excellence on Chronic Pain for Veterans, thank you for attending today. I wish you a happy summer. I thank you, and see you soon.